It's a great honor to be here today and to a really packed house. I have to say one of my former patients was Marion State, who was very involved in this support group, and she would be very proud to see how many people are in attendance today. I just wanted to point out that I have my ribbon, and although I don't have shoes to put it on today, I will put it on my bag before I leave here today. So David asked me to talk to you about updates from the American Society of Hematology meeting that was held this year in December. At this meeting, what we do is usually present pivotal data from clinical trials from, is the sound okay? Yeah. From essentially done around the world. And this is really sort of what is really upcoming information about new drugs and new ways to treat myeloma. So I've got the daunting task of presenting a lot of data today. I hope you'll bear with me. If you need a break in between the talk, we talked to David and I said we can either take a break during the session or after the presentation. I'd just like to present my disclosure. I do have affiliation with a number of pharmaceutical companies as we do a lot of research at Princess Margaret Hospital. And so just to present you an overview of what I'm going to be talking about today, I'm just going to give you a little bit of a background on clinical trials so that you understand, sort of get a flavor for how the data is presented to us at this meeting and what the significance of that data is when you have a better understanding of what's involved with clinical trials. And a lot of the slides on this session are slides that I borrowed from one of my colleagues, Dr. Chris Chan, who presented last year at this meeting about updates of myeloma. She did a wonderful job, and so I asked her if I could borrow some of her slides just to put everybody on the same page for understanding clinical trials. And so I apologize for some of you who've already seen some of these slides, but I hope that it will be a refresher for everyone. Then I'm going to sort of present a little bit of an overview of what drugs we have available for myeloma currently and how we use these in the management of patients from initial diagnosis through various stages of their disease. Again, sort of trying to put in a little bit of a framework to understand the questions that are asked in clinical trials. And then as far as the clinical trials section, talking about the updates from ASH, I've sort of broken them down into three areas. One is trials that we're looking mainly at treatment of myeloma patients when they first present with disease and how we treat them initially. And the focus this year at ASH was a lot of studies presented in patients that are transplant eligible. Then, as unfortunately many of you know, myeloma is not a curable disease. Eventually, all patients will eventually progress after their initial therapy and require more treatments. So then we'll talk about treatments for those patients that were presented at this meeting, and we'll also talk to you about the new and exciting drugs that are in the pipeline for the treatment of myeloma. So again, this was presented last year, and I thought I gave you a very nice overview of the process of drug development. It applies to myeloma and all cancers. So first of all, we have an idea. The scientists sort of have some theory about what allows the cancer cell to grow. And perhaps if we can prevent those signals to the cancer cells or how the soil causes the cell to grow, and we can target it and turn them off, the cancer cell may die. Once we have this idea and we've proven it in a scientific manner, then essentially we have to turn that idea into a drug or a therapy. And that is what we call translational medicine. Once we have a drug or a concept for a new therapy based on this idea, we need to then put it into the clinic and test this idea. And this is done in clinical trials. And usually you have a phase 1, a phase 2, or phase 3 trials. And in subsequent slides, I'll explain to you what these trials involve, phase 1, 2, and 3. But a phase 3 trial is a trial where we basically show that the new treatment is more effective than what we have currently. Once that is shown, then usually that will be a signal to the drug company that they then need to apply to a regulatory body. In Canada, that would be Health Canada. In the US, that would be the Food and Drug Agency, or the FDA, for that drug to be approved and to be able to be marketed for myeloma in Canada. Once that process is done of the regulatory approval, then the next hurdle is getting funding for the drugs. And this can be quite a task, and this is why Martina, who you've heard about, is very involved in trying to help get reimbursement for drugs once they get approved. And that usually takes a couple of years from the Health Canada saying, yes, this drug has shown benefit for myeloma patients, it should be marketed in Canada, to getting funding for the drug and everybody having access to these drugs. So, as I mentioned to you, the steps for the trials, first we go through a phase 1 study. So this is usually for either a new drug that's not been tested before in humans or in myeloma, or a new drug combination, drugs that have never before been put together. What the purpose of a phase 1 study is really to show the safety of the drug. We want to know what the side effects are of the drug, that it is safe to be given to patients. Usually that involves starting with low doses, testing it in a few patients, seeing that it's safe, escalating the dose up and up until we find the dose that is safe to be used, where we think that is the maximum tolerated dose that we can give to patients. Once that phase is done, then you go on to the phase 2 part of this drug development, which is essentially to show that the drug actually has activity in myeloma, that it is an effective drug. That usually incorporates more patients, and all the patients will be usually dosed with the drug at the recommended dose. And that's what they do there, is they look for responses, how many patients are responding to the treatment, what is the length of their response as well. We also look to see what is, again, the safety of the drug in those phase 2 studies. Once that shows there is benefit to patients with myeloma, then we go to the phase 3 study. In a phase 3 study, where what we do is we randomize patients. So half the patients will get the new treatment that we are studying, and half the patients will usually get the standard therapy. And we will therefore look at the two groups and see whether or not the new treatment is more effective than the old treatment. And the markers of efficacy can be response, they can be how long the treatment controls the disease for, or it could be how long do patients live with this new treatment. If the new treatment is more effective, then as I said, then the companies will then go to Health Canada to try to get regulatory approval for the drugs. The phase 3 studies are usually incorporate large numbers of patients, usually 300 to 400 to 500 patients per treatment group, the control group or the new treatment group. Once a drug is then gone through phase 3, and if it looks like it's going to get regulatory approval, sometimes companies will then run what we call phase 4 studies. And phase 4 studies are essentially studies where all patients are getting the treatment, and we're looking for safety signals, because you may get rare but significant toxicities, side effects from a drug that you may not have picked up in a trial, where you've only looked at 1,000 patients. You may need many more patients to be able to pick up these rare but important side effects. Okay, so here I've sort of illustrated what we see when we go to the ASH meeting. This is an example of a slide that would have been put up at the meeting, where it basically shows the design of the study and what the endpoints are, what the goals of the study, what we're looking to see as far as an outcome. What you see here is this is the STAMINA study, which was done in the United States, where essentially the question is what is the best treatment for a patient after they've had a single stem cell transplant? Is it to just go directly to maintenance treatment? Is it that they should get more intensive therapy before they get to maintenance treatment? So then in the dark blue here. or should they get another transplant, so what we call tandem transplants, and then go to maintenance treatment. And this study was randomized, so a third of the patients would have had a single transplant, a third of the patients would have had what we call consolidation treatment, so more treatment with bortezomib, lenalidomide, and dexamethasone, and a third of patients would get a tandem transplant and then go on to get lenalidomide maintenance. These patients would be assigned to these groups blindly, after they've had their first transplant. So the control group is the single transplant. That is what we do as standard of care normally for treatment of myeloma patients. And the other two groups are the experimental groups. Now, what the question is asking is there a benefit to these additional experimental groups, to these additional therapies, another transplant or more consolidation treatment? So the way that we answer this is we look at the endpoints which would be progression-free survival, which essentially means how long did that treatment control the disease before people actually progressed. Secondary endpoints are additional questions that would have been asked within the study, and those would include OS, which is overall survival, how long did people live who got each of these treatments. What was the response rate, so how many patients responded and what was the depth of the response. Safety, so what were the side effects that were seen in the patients on this study. What were the treatment-related deaths, so what if patients died during the study, what did they die of, and what is the quality of life for patients in each of these three arms. So those we call the key endpoints for a study. Okay, so how do you get onto a clinical trial? I see many of my patients in here, and I think quite a few of you have been on clinical trials at Princess Margaret. So the first thing is to ask your treating physicians, are there clinical trials available for me, for my stage of the disease, for instance? If you are interested in the study, then usually the myeloma team will then go look at what trials we have open for which you may potentially be a candidate. And then we may do a little bit of a screen looking at your blood work, looking at your prior therapies to see if you would potentially be eligible for the study. So not all patients can go on trials. Each study usually has what we call eligibility criteria. So your blood counts have to be a certain level, your kidney function has to be within a certain parameter, for example. If you are eligible for a study, then usually we will give you an overview and let you know what studies you may be eligible for. And that may be a discussion that you have with your physician or what we call clinical trial coordinators. These are usually nurses that are helping us run the trials. You will get a consent form, and that consent form will explain to you what the trial is about, what the questions we're trying to answer, what the treatment is, what the potential side effects are, what's involved as far as additional testing, and what for the study. It is important for you when you do go through an informed consent to consider a trial that you bring family or friends, because there's a lot of information to absorb, and it's helpful to have extra ears. We don't want you to sign the consent when we first give it to you. We want you to take it home, read carefully what's written in there so you know what's involved. And then if you agree to do the study, then we bring you back to sign the consent and start the screening process. Okay, so what questions should you ask when you're reviewing a consent form or considering a trial? So what are the details of the treatment? So for example, is it oral? Is it intravenous? How long? If it's intravenous, how long are how long is the treatment for? Is it an hour? Is it 7 hours like we see for Daratumumab? How often is the treatment given? How long are you going to stay on the treatment? Is it continuous indefinite, or is it a year's worth of treatment? And also what we say is there a crossover. So for example, if you're on a phase 3 clinical trial where you're, let's say, assigned to the control group, you're not getting the new treatment, is it possible for me to go on to get the new treatment if I progress on the standard therapy? That's what we call crossover, so that you can also get benefit of the new drug. Will you always get treatment or is it randomized? So for example, in the phase 2 study, you will most likely, in most cases, always get the new treatment. If you're on a phase 3 study, you will likely be randomized either to the control group, the standard treatment, or the new treatment. Will you know what treatment you're going to get, or is it blinded? So a lot of studies, if it's intravenous, for example, treatment, you will know that you are getting the new therapy that is being tested. But if it's an oral therapy, there is potential that you may not know whether you or not you are on this new investigational study drug. You may be on the placebo, and your treating physician may not know as well. And the reason for that is so that we don't have bias, because if we know that you're on the study medication, we may attribute side effects to the drug, but if we're blinded, then we don't have those biases. Okay, important is to know what extra tests you're going to need. Okay, often a lot of clinical trials nowadays will require to have a bone marrow done, and that bone marrow we usually do so that we can try to understand how the new treatments are working. By looking at the effects of the new treatments on the myeloma cells within the bone marrow. So you may need to have a bone marrow that you would not normally need to have done. You may need extra x-rays or CAT scans, extra blood tests when you go on to a clinical trial. And then you really want to know what are the most common and serious side effects. So if it's a new drug that's not being tested before in humans, like in a phase 1 study, you may have very limited information about what the potential side effects are. But certainly if you're involved in a phase 2 and certainly a phase 3, we usually have a good idea of what the common side effects are and which are the side effects that may be most serious. It's also important that when you consider the side effects that you want to make sure that those side effects are not going to exacerbate some of the symptoms you may already have from previous treatments. So for instance, if you have neuropathy, which a lot of patients have, that numbness and tingling in the hands and the feet, does this new treatment potentially cause neuropathy that may make your neuropathy worse? And are there any extra costs? So often these studies require you to come to the hospital more frequently than you would otherwise. We know it's very expensive to park downtown at Princess Margaret Hospital. Are you going to have to absorb this cost? Some of the studies, particularly if the studies are funded by pharmaceutical companies, will pay for the cost of parking and even sometimes lodging and meals. So ask about those things. So before we start to actually talk about the clinical trials, I thought it was very important for us to have an understanding of what drugs we have to treat myeloma and how we treat myeloma today in 2016, to give us an idea of what the clinical trials that were presented at ASH this year are building on. Okay, so we have been very fortunate in myeloma that in 2016 we had 4 new drugs approved for the treatment of myeloma. So you can see here that up until the 1990s, there really had been no progress made in myeloma except for the introduction of stem cell transplant. In the 2000 period, we saw the approval and the common use in the clinics of what we call the immunomodulatory drugs, so thalidomide, lenalidomide, and pomalidomide, and also a new class of drug we call the proteasome inhibitors, so bortezomib. And then in 2016, we saw the approval of carfilzomib and ixazomib. These are in the same class of drugs as bortezomib. They're proteasome inhibitors. And we also saw, for the first time now, we have what we call monoclonal antibody treatment for myeloma. So elotuzumab and daratumumab. So carfilzomib was approved from Health Canada, and it can be given either with Revlimid and dexamethasone, or it can be given just with dexamethasone. It is not yet funded in Ontario, but there is a compassionate program, and some insurance plans will cover the cost as well. Elotuzumab was approved in combination with Revlimid and dexamethasone. However, it is not going to be marketed in Canada. And then we have daratumumab, which was approved for patients with very advanced myeloma. those patients that have failed a proteasome inhibitor and an immunomodulatory drug, or have had more than 3 lines of treatment. However, at this point in time, this drug is not funded anywhere in Canada. So how do we use these drugs? So we use the drugs, the classes of drugs, what we call the immunomodulatory drugs, or the proteasome inhibitors, or the monoclonal antibody now, as backbones. We use them in combinations. We use them in combinations either with chemotherapy, such as cyclophosphamide or melphalan, or with steroids, or we use them in combination together, so proteasome inhibitors and immunomodulatory drugs. As I mentioned, the immunomodulatory drugs are lenalidomide. Many of you may know it as a Revlimid. Pomalidomide, many of you will know it as Pomalyst. So just keeping that in mind, because most of the studies will use the lenalidomide or pomalidomide name as opposed to the commercial name. Proteasome inhibitors, bortezomib or Velcade, carfilzomib or Kyprolis, or ixazomib or Ninlaro. In the monoclonal antibodies, we have elotuzumab, known also as Implicit, and daratumumab as Daratumumab. So the immunomodulatory drugs, how do they work? Well, they work partly on the tumor cells themselves, but also interestingly as well, they work on the microenvironment, meaning the setting in which the soil in which the tumor cells are growing. And importantly, they work on the immune system. They are able to activate your own T cells, the immune cells, to recognize the tumor cells and cause killing of the tumor cells. So they work in a number of mechanisms. That's partly why they're so effective in myeloma. So I mentioned to you there are 3 different immunomodulatory drugs. The common side effects of those drugs are sedation or fatigue, risk for blood clot, neuropathy, very strong neuropathy with thalidomide, less so with pomalidomide and lenalidomide, and it can cause either constipation or diarrhea. And with lenalidomide and pomalidomide, we also see potential for decrease in your blood counts. Now, proteasome inhibitors, what they do is essentially they inhibit the proteasome. They prevent the proteasome from working. And the proteasome is important to allows the degradation of proteins in the cells. And myeloma cells make a lot of protein. They make antibodies, right, that we use to fight infection. So if we block that proteasome, we prevent the antibodies from being degraded in the tumor cell, and the tumor cell gets stuffed with all these antibodies, and we think that's partly how they cause the myeloma cells to then die. And we have bortezomib and ixazomib, which block a number of the components of the proteasome inhibitor from functioning. And we have ixazomib, which is, as I said, just got approved. The nice thing about ixazomib is that it is oral. This is the first time we've had a proteasome inhibitor that can be taken as a pill form. And then we also have the carfilzomib, which really just blocks one part of the proteasome. It is more specific and therefore has a little bit less toxicity, particularly less neuropathy associated with it. So it's really nice now to be able to have 3 different proteasome inhibitors with different side effect profiles, and importantly, one that now can be taken by pill. Now, the monoclonal antibodies, they work by a number of mechanisms, but one of the mechanisms is essentially the monoclonal antibodies will bind to a surface protein on the tumor cells, and that binding will then recruit immune cells, here we call these NK cells, to come and attack the tumor cells, okay, and get rid of the tumor cells. And in myeloma, there are a number of different markers on the tumor cells that we can target, and 2 of these have been approved by Health Canada. Daratumumab, which targets CD38, and elotuzumab, which targets SLAM-F7. Okay, so when we go through, now we'll start going through what was presented at ASH. Again, I'll give you a little bit of an idea with each section how we would standardly treat for example, initial myeloma. So for patients who are initially diagnosed with myeloma, we essentially divide them into two groups, those that are transplant candidates and those that are not felt to be transplant candidates. That's usually patients over the age of 70, although that is not a hard stop. We realize that there are some over 70-year-olds that are very fit. And really the most important thing is how fit is the patient to go through a high-dose chemotherapy, which has a lot of side effects, potential risk for death, and also long recovery period to decide whether or not a patient is eligible for transplant or not. So if you're not eligible for a transplant, then the treatment is usually bortezomib or Velcade combined with prednisone and melphalan. Now, we're lucky in the last 2 weeks ago, Ontario funded lenalidomide and dexamethasone for patients that are non-transplant eligible. Nice thing there is this is pill treatment, and again, the efficacy data looks very comparable to what you would get with VMP, but you have a treatment that's all given by pill form, whereas the Velcade you need to come to the hospital once a week for injections. Now, if you're a transplant candidate, then the treatment is divided into 3 phases. One, we call the induction phase, where patients will get treatment. Here in Canada, we use cyclophosphamide, bortezomib, and dexamethasone. Many of you know familiar, we call it Cybor-D. Nice to know that that treatment was actually developed here in Toronto. First, we developed it in patients with relapsed disease, but then moved the treatment up front. And that was a clinical trial that we did in combination with Princess Margaret and the Mayo Clinic when Keith Stewart left to go from Toronto to the Mayo Clinic. So this is a small study that we did that led to new treatments for transplant eligible patients that is used across the world now. The second part is the stem cell transplant, and then the third part is lenalidomide or Revlimid maintenance. So this is how we would typically treat a myeloma patient. Now, how can we improve on the results that we get with this current therapy? Well, for strategies for patients who are transplant eligible, can we make the induction treatment before the transplant, can we make that better? Or can we make the post-treatment after transplant better? Either using consolidation, which means more intensive therapy, such as another round of bortezomib in combination with other treatments before we go to the maintenance, or considering another transplant, or what is the role of maintenance? Should we be using maintenance to further improve our results that we get with patients who are transplant eligible? So this was the Myeloma 11 study that was presented at ASH this year. This was a study that was done in the UK. And here essentially what it involved was newly diagnosed patients. There were 583 patients enrolled in this study. And those patients were randomly assigned to either get cyclophosphamide with Revlimid and dexamethasone, or cyclophosphamide, thalidomide, and dexamethasone. After 4 cycles of treatment, they assessed the response for the patients. And if the patients really didn't get a very good response, meaning that there wasn't at least a 50% reduction in their myeloma M protein or light chains, their measurement of their disease, then those patients were assigned again to get more treatment. And that would be either they could get bortezomib, cyclophosphamide, and dexamethasone. So what we're doing here is we're switching the backbones. We're switching from an immunomodulatory drug to a proteasome inhibitor. Or those patients were assigned to not get any further therapy and go right to stem cell transplant. So the question was, does changing the therapy for patients who've had a suboptimal response to their first 4 months of induction, does it improve their outcomes? And the outcome here was progression-free survival, or the length of disease control, and overall survival. And as the results of the study, and the answer is yes, okay? So here what you're looking at are curves looking at both progression-free survival, so the time before patients progressed, and overall survival. In the blue here, you see these are the patients who had more therapy receiving bortezomib, cyclophosphamide, and dexamethasone. And these were the patients who were assigned to the no more treatment, go right to transplant. And you can see here that the patients who had more therapy before their transplant, fewer of them progressed it took longer for more patients to progress, or 50% of the patients to progress. So on average, the patients who received more treatment their disease was controlled for 28 months. I should correct that. So the patients who did not receive more treatment, their disease controlled was for 28 months, whereas if you received more treatment, your disease was controlled for 48 months. So 20-month improvement. At this point in time, we don't see a benefit as far as how long people live. So yes, changing the therapy to a proteasome inhibitor combination compared to no further treatment and going right to transplant does improve the outcomes for patients who have a suboptimal response to their initial therapy. So the next study was a study that was basically a French study that was presented. In that study, this is a phase 2 now, so the patients are not randomly assigned. Everybody gets the same treatment. So what these patients got is now looking at using a newer proteasome inhibitor, carfilzomib, instead of bortezomib, combined with lenalidomide or Revlimid and dexamethasone. 4 cycles of this treatment, then stem cell transplant, and then an additional 4 cycles of the same thing, carfilzomib, lenalidomide, and dexamethasone, and then lenalidomide or Revlimid maintenance. The primary endpoint here was response. Were the responses better if you received this new treatment? And how deep were the responses? Because we do know that achieving the deepest possible response does correlate with longer control of the disease. Okay, so essentially the results of the studies were shown here. So 8 cycles of induction followed by consolidation showed a complete response rate of 61% at the end of consolidation. So this is a very high response rate. On average, we would expect just with a stem cell transplant a complete response rate of about 30% or so. So this is about double what we would expect. And in fact, 70% of patients were what we call minimal residual disease negative. So that means that when they did the bone marrow on the patients after they received their consolidation treatment, they could not find 1 in a million cells in the bone marrow that were myeloma cells. And this is really becoming the new standard. We really want to try to get patients to MRD negativity. So these were good results. Deeper responses we think, will likely lead to longer benefit. However, the downside of the study, there was less neuropathy, but there was a cardiac signal. There were more incidences of heart disease noted on the study. So that's important to keep in mind, and it may mean that certain patients may not be able to get this kind of treatment, and it may be treatment for certainly younger, fitter patients that are less at risk for heart issues. This type of approach will likely be studied in a phase 3 clinical trial where we'll compare this type of approach to what the standard treatment would be, which would be essentially proteasome, Cyborg-D, for instance, transplant, and then lenalidomide maintenance. Another study that generated a lot of buzz at ASH for, again, newly diagnosed transplant-eligible patient was the Stamina study. So this was a study that was done in the United States. This is the one I gave you the example of earlier. So patients here were treated out in their community with whatever the standard treatment would be for induction. And then they went on to their transplant. And after their transplant, provided that they had not progressed, they were randomly assigned to getting no more treatment, just len maintenance, more treatment, consolidation treatment, or another transplant. The question here was, is there added benefit to giving more intensive therapy after the first transplant, either consolidation or another transplant before going to maintenance treatment? And interestingly enough, the results were no. There was actually no benefit to giving more intensive therapy after the transplant. You can see here that the curves completely overlap, both as far as progression-free survival, so the length of disease control, and overall survival. This study was conflicts with other studies that have been done, for example, in Europe, where they do see in those studies that there is added benefit to consolidation treatment after a transplant or a tandem transplant. One explanation may be what the treatment was that was given up front. In the United States, a lot of patients get Revlimid, bortezomib, or Velcade, and dexamethasone, and we think that if you can get that triplet up front, you may not need it later on. In Europe, a lot of places use Cybor-D, and perhaps using a triplet or consolidation treatment after the transplant may then be required. So those kinds of questions still need to be addressed. So the outcome of this study is still unclear how it will impact us. So the last study for non-transplant and transplant-eligible patient was again the study from the UK, the Myeloma 11 study. So there was another part to the study, and that was to look at maintenance treatment. So when patients had completed either their transplant or their, let's say, VMP, for example, for non-transplant eligible patients, they were then assigned to either get nothing, placebo, or to get lenalidomide maintenance. Again, the idea here was, is there benefit to lenalidomide maintenance, as has been shown already by a number of other clinical trials, because many of you have already heard about maintenance treatment with lenalidomide and why we recommend it, because there are lots of studies actually showing the benefit to lenalidomide maintenance. And the study was, yes, there is, like all the other studies, marked benefit to getting lenalidomide maintenance if you've had a stem cell transplant. You can see here, this is the blue curve showing the patients with lenalidomide maintenance have 50 months of disease control versus 28 months if patients got placebo, nothing. And also there's benefits for patients who don't have a stem cell transplant. So these patients, again, you can see here, the progression-free survival is 24 months versus 11 months for patients who didn't undergo a stem cell transplant. An important question that was answered in this trial is often patients will ask me, well, how long do I need to stay on maintenance? Can I not stop it after a year? Do I need to remain on it indefinitely? Which a lot of people, I think, find it a hard pill to swallow when we say, yes, you have to stay on it as long as your disease is controlled. Well, here we can see that actually this is the case, that if you were on the treatment only for less than 12 months, you had a shorter disease control than if you stayed on for greater than 24 months. So it does suggest that duration of therapy matters and that you should remain on treatment with lenalidomide. So what are the take-home messages from the upfront treatment for myeloma patients from ASH this year? So does improving induction therapy matter? Yes, if you had a suboptimal response to your initial induction therapy, likely that treatment should be tweaked in order to try to get a better response before transplant. Usually we do that by switching the backbone agents. How can we improve? Can we improve the outcomes by changing treatment after transplant? So maintenance therapy, and if you have maintenance treatment and a good induction therapy, you may not need consolidation treatment. However, again, that area needs further investigation. Now, carfilzomib Rev-Dex to be used upfront in consolidation treatment, the data were very intriguing, that the response rates and the depth of response particularly were very good in that study. We expect that that will translate into better outcomes, longer disease control. However, that needs to be studied, and that will likely be studied in a phase 3 trial. We need to keep in mind the increased risk of cardiac toxicities. And then maintenance, the studies confirmed what we already knew about maintenance treatment, that it really does improve time of disease control after transplant, and also importantly, that patients need to remain on continuous therapy, and that is the approach that we are currently using at Princess Margaret. Now, for the relapsed patient population, the things that we factor in when we make a decision about what treatment we're going to use for a patient when their disease recurs after their initial treatment are things like, how is the drug given? It's important for patients' quality of life, accessibility to coming to the hospital, the side effects that are associated with the drugs, how are they cleared from the body? So if somebody has issues with their kidneys, some of the drugs may not be ideal for those patients because they won't be cleared and there'll be extra side effects from those patients. Are the drugs funded? That's a very important question. Patient characteristics, so what kind of does the patient have a lot of neuropathy? Do I need to try to avoid drugs that cause neuropathy for the patient? The geography to the hospital, again, very important for whether we consider oral treatment or IV treatment, age of the patient, and of course we much take into consideration the patient's preference on therapy. And then the disease characteristics. Does the patient have high-risk disease? In those cases, maybe we want to treat with very aggressive 3-drug treatments. What was their prior therapy? How did they respond to it? So up until recently, the treatment for a relapsed patient was, one, we would consider doing another transplant if somebody had a long remission from their first transplant, and by that we usually mean more than 2 years. Otherwise, we use combination treatments that either are based on a proteasome inhibitor, bortezomib-based treatment, or lenalidomide, Revlimid-based treatment. When the patients fail those therapies, then typically we would use Pomalidomide. Or what we often do is consider clinical trials for patients. So again, the bortezomib-based treatments and the lenalidomide-based treatments are for heavily pretreated patients, less heavily pretreated patients, and the Pomalidomide dex are for patients who've had previous exposure to both proteasome inhibitors and immunomodulatory drugs and more than 2 lines of treatment. So what has changed over the last year or two is really been, again, data that suggests that we can improve on the outcomes of these IMiDs, lenalidomide and proteasome-based doublets by using triplets, so adding a 3rd drug to these backbones. So for instance, if we add carfilzomib to lenalidomide and dexamethasone, we now get good disease control for 26 months, elotuzumab 19 months, ixazomib around 20 months. And the data with Daratumumab, which I will show you updated data from ASH this year, is remarkable. We can't even as of yet project how long patients are going to obtain disease control with that triplet combination. This is superior to what you would get with the doublet. As you can see in these studies, in the control arm of lenalidomide and dexamethasone, the progression-free survival ranged between 15 to 18 months. Now, for bortezomib, the studies there trying to improve on bortezomib dex either added a new agent, such as daratumumab again. We have not yet seen what the ultimate PFS is going to be for that combination, and I'll show you again updated data from ASH on that study. Panobinostat plus bortezomib dex gives a progression-free survival of about 12 months, or if we switch to the newer proteasome inhibitor carfilzomib, we see now a progression-free survival of 18 months. And this is compared to bortezomib dex, where in the studies the progression-free survival ranged from 7 months to 9 months. So each of these studies, either adding or switching agents, showed a better outcome, and that's what led to the approval of these drugs by Health Canada. Now, for patients who have failed, who've progressed on a proteasome inhibitor, most nowadays will be bortezomib or lenalidomide. For those patients, we either will give them pomalidomide and dexamethasone, and that we expect from the clinical trials patients to have disease control for only 4 months, survival of about a year. Or recently approved by Health Canada is Daratumumab, which gives, again, about a disease control of about 4 months and a little bit better overall survival. We definitely think we can do a lot better than this for patients who have more advanced myeloma. And a lot of the studies presented at ASH look at either adding another drug to these 2 drugs or actually very new, novel mechanisms by which we can control the myeloma. Okay, so now with the approval of these drugs, this is how we are now treating relapsed myeloma. Again, we will consider another transplant for patients with long remission. But for patients who had a short remission after transplant or who don't think that they want to go through another transplant, we will usually use lenalidomide and dexamethasone in combination with carfilzomib or ixazomib, or we can use carfilzomib and dexamethasone or Cybor-D. And again, for patients with more advanced disease, we're looking at pomalidomide and dexamethasone, as daratumumab at this point in time is not funded. So, do we have better therapies for patients with relapsed myeloma? These were the questions that were asked at ASH this year, looking both at patients that are less heavily pretreated, meaning they've had 1 to 3 prior lines of treatment, or the more heavily pretreated patients, and then some totally new approaches using drugs that work completely differently from what we have currently available in the clinic. So, sorry, I think So the first study, as I mentioned to you, there was data presented at ASH this year updating the information on daratumumab combined with lenalidomide and dexamethasone. So this again was a phase 3 randomized studies where patients were relapsed after their first treatment and were not heavily pretreated. Most patients had had maybe 1 to 2 prior lines of therapy on this study. The patients could not, on this trial, have failed or progressed on lenalidomide. So if you had lenalidomide and you progressed on it, you were not eligible for this study. Patients were randomized. Half the patients got daratumumab, lenalidomide, and dexamethasone, and half the patients just got lenalidomide, dexamethasone, which I had said was up until very recently the standard of care. And the primary endpoint of the study was progression-free survival. How long do we control the disease? So again, this study led to the approval of daratumumab in combination with lenalidomide and dexamethasone. Actually, it hasn't been, that combination, I should say, so I'll correct myself, has not yet been approved by Health Canada, but it is going through the Health Canada approval, okay? And we think it is going to get approved because the data is remarkable. So we can see here that in the pink is the progression-free survival of patients who were on lenalidomide and dexamethasone. And this is the progression-free survival of patients who got daratumumab, lenalidomide, and dexamethasone. And we can't, when we talk about the median PFS, that's how long before 50% of the patients progressed, we can't even estimate what that will be, because at 2 years, only 20% of the patients have progressed. So this is really, we've never seen such dramatic results in a relapsed patient population. You can also see that the patients also benefited because there was a higher response rate. So 93% of the patients responded to this triplet combination versus 76% of patients who received lenalidomide and dexamethasone. And the responses were deeper. So more patients, and I'll show you that data, achieved minimal residual disease. Now, they were also presented at this meeting the updates on the CASTOR study. So the CASTOR study was very similar, a clinical trial, phase 3, where patients that were not heavily pretreated. In this study, patients could not have progressed on prior proteasome inhibitors, so for example, Velcade. Patients were randomized, 251 patients were assigned to daratumumab, bortezomib dex, and 247 patients received bortezomib dex. And again, the primary endpoint was progression-free survival. And again, you can see remarkable results where in the purple is the patients who received the triplet, in the yellow, the patients who received bortezomib, dexamethasone. And again, now we're starting to approach the 50%, where we would say this is the progression-free survival for 50% of the patients, but we still are not there yet. So it's going to be more than 24 months. And here we see again that if you had the triplet, you had a higher response rate of 84% versus 63%. So the other important data that was presented on ASH looking at these two studies was what was the depth of the response, because we do think that if patients can achieve minimal residual disease status, in this case 1 in 100,000 cells, that those patients are going to be in remission for a very, very long time. And you can see in the purple, so this is the Pollux study, so this is the study looking at daratumumab, lenalidomide dex, and the castor, bortezomib, lenalidomide, and bortezomib, dexamethasone, and daratumumab. Here we have patients with high-risk disease. In the purple are the patients who received a triplet. And you can see there was a higher percentage of patients that achieved minimal residual disease in the high-risk group. There were no patients in the high-risk group who achieved minimal residual disease without the addition of daratumumab. You can see also here that the non-high-risk patients, more patients achieved minimal residual disease, 30% versus 10%. And also in the castor study in combination with bortezomib, again, no patients with high-risk disease achieved MRD. And again, more patients who had the daratumumab, even in the standard risk group, had MRD, that depth of remission compared to patients who just received bortezomib dex. So the conclusions from their study is that the triplets essentially significantly improve outcomes for patients with relapsed myeloma. Again, this data is now being put forward to Health Canada for approval of those combinations. More patients achieve deeper responses, and we think that that will be associated with better outcomes, and that the deeper response were independent of high-risk cytogenetics, and the safety signal looks very good. So with longer follow-up, we're continuing to watch for long-term side effects of being on these novel drug combinations, and so far we don't see any cumulative toxicities. Now we're going to move on to new treatments for patients with sort of more advanced disease. Those patients where, bortezomib or Velcade is no longer effective, or those patients where lenalidomide is no longer effective. And this is certainly an area of interest for me from the research perspective, because we're always looking for new drugs. So just to say that, as I mentioned earlier, for those patients currently, we would use pomalidomide and dexamethasone. Again, reminding you that the results of pomalidomide and dexamethasone are not optimal. Based on the original phase 3 clinical trials, we would expect a progression-free survival or disease control rate of about 4 months on average. So 50% of patients after 4 months would progress on that treatment. And so we think we can definitely do better. Right now, many of you who are going on pomalidomide and dexamethasone because we're not happy with 4 months, we usually use it in combination. We'll often add Biaxin or cyclophosphamide or Ninlaro or Velcade. But really the way to go is to use it in a triplet combination. And I'll show you some data on triplet combinations with pomalidomide. And then you've heard about daratumumab again, which shows again a progression-free survival similarly of only about 4 months. Daratumumab, as I mentioned to you, is approved for this indication for advanced myeloma, but not funded. And then I'll talk to you about some of the drugs that are the most sort of promising that were shown at ASH this year that are new for myeloma. One drug is pembrolizumab, which many of you may be familiar with because there's a lot of commercial on TV about these PD-1 inhibitors for lung cancer and melanoma. They work by essentially unclothing the tumor cells so that the immune cells can see them and attack them. So we know that tumor cells are very sophisticated. They can basically make themselves invisible to the immune cells. They can kind of cloak themselves. And what this class of drugs we call checkpoint inhibitors or PD-1 inhibitors or PD-L1 inhibitors, what they do is they uncloak the cells. So now the immune cells can say, ha-ha, there's a tumor cell, I'm going to attack it. There's also a drug called Selinexor, and to say that this drug has been mostly developed in clinical trials in Canada. We can be very proud in Canada of how many patients we've put on this drug, and the results that were presented at ASH, a lot of them are derived from patients from Canada treated with Selinexor. Then there's another drug called Venetoclax, which is used in CLL, but we're now trying to see if it works in myeloma. And then also BCMA, so B-cell membrane antigen, which is a marker on the myeloma cells, is becoming a very attractive target in myeloma. We can target it using these drug-conjugated antibodies, but there's also studies going on looking at what we call bispecific T-cell engagers, the BiTEs antibodies, and also CAR T-cells. So those are all immune types of therapies, and I'll just show you some data on GSK 285716, which was a drug that we've been studying at Princess Margaret Hospital, and some nice data on that agent. So again, just mentioning Pomalidomide, Health Canada approved and funded in Ontario for patients who have failed bortezomib and lenalidomide and received 2 prior lines of therapy. It is under investigations in combination, and the data I'll present to you is a combination with carfilzomib, so again, a next generation proteasome inhibitor, and with pembrolizumab, a PD-1 inhibitor. Okay, so this was a phase 1/2 study. So again, phase 1, the first part of the study was looking at combining carfilzomib and pomalidomide and dexamethasone and finding the doses of each drug that are tolerated and are safe to use in combination for patients. So, and then the phase 2 portion of the study would have basically put on more patients at what we felt was the optimal combination dosing of the 3 drugs. That's what we call the maximum tolerated dose. And so those doses were 27 milligrams per meter squared of carfilzomib with 4 milligrams of pomalidomide and 20 milligrams of dexamethasone given on the carfilzomib days. Okay, and there were 48 patients treated on this study. And the primary endpoint was to identify the doses of the 3 drugs to be combined and to look at the response rates. So the combination was found to be very active, and I forgot to mention, important with this study here was that they looked at giving carfilzomib just once a week. Okay, so right now carfilzomib is very onerous for patients. It requires you coming to the hospital 2 days a week for 3 weeks in a row. So 6 visits just for the carfilzomib per month. So one of the attractive features of the study was not only to see, do we do better, do we get better responses when we combine 3 drugs, but also do we make this more palatable for patients because we're looking now at giving the carfilzomib just once a week. So anyway, so the combination, even with carfilzomib dose once a week, showed a very high response rate of 64%. With Pom-Dex, we would expect a response rate of about 30%, so it was about twice what we would expect with just using the doublet. And the progression-free survival was also about twice what we would see with just using the doublets. So excellent results. And again, importantly, was that the carfilzomib was just given once a week to make things more convenient for patients. And there was also, I've mentioned to you, some concerns with carfilzomib with regards to cardiac risk. So this study imposed in it very careful, close monitoring of blood pressure. Before carfilzomib dosing, after carfilzomib dosing, treatment of high blood pressure and monitoring at home. And with that, they found that they were able to reduce the cardiac toxicity risks. So the next study combined pembrolizumab, again that PD-1 inhibitor that allows the immune cells to now visualize the tumor cells, combined with pomalidomide and dexamethasone. The study was to look at the safety of giving those 3 drugs together and the efficacy. What was the response and the duration of responses of that combination, that triplet combination. So essentially 48 patients were treated. Again, these were patients with more advanced myeloma where bortezomib and lenalidomide were no longer effective. And the pembrolizumab was dosed on every 2 weeks. And then the pomalidomide was at 4 milligrams, dexamethasone at 40 milligrams. And then for patients, for the responders, they were able to continue on treatment, but the pembrolizumab was reduced to once a month. The primary endpoint was safety, because this was a study really aimed at can we combine these 3 drugs together, and the secondary endpoints were looking at duration of responses and the responses. So in this small study, the results were very impressive. So the responses were 65%, again, about double what we would see with just the doublet of pomalidomide and dexamethasone. But what really struck us was the progression-free survival. Here we're seeing now that you're getting disease control for almost 1.5 years compared to 4 months. So this is really impressive data, and really encourages the use of these types of agents now, not just in melanoma and in lung cancer, but now in myeloma. We need to study these kinds of drugs in combinations in patients with heavily pretreated, and now there are clinical trials looking in patients with earlier disease as well. And we have some of these studies open at Princess Margaret. So one potential concern with these classes of drugs is that because they activate the immune system, there is a risk for autoimmune reactions where then not only will the immune system attack the cancer cells, but can attack your own tissues. So they can affect the lungs and cause something called pneumonitis, or they can affect the colon, cause colitis. So again, these classes of drugs are very commonly used by what we call the solid tumor doctors, the doctors that treat lung cancer and melanoma, and they're very familiar with these types of drugs and what kind of side effects and how to monitor patients. This is something that we need to have a little bit more experience with, and I think we will be getting that in the upcoming trials. So Daratumumab, as I mentioned to you, is a monoclonal antibody. It binds to CD38 on the myeloma cells, and it allows the immune system, again, attracts the immune system to the tumor cells. The approval by Health Canada was based on a study in very advanced myeloma, where basically myeloma patients had no further therapeutic options. And in that patient population, there was a response rate of 29%, and again, disease control of about 4 months. So this study here presented at the ASH this year essentially looked at giving daratumumab by subcutaneous injection. So one of the issues that we face with daratumumab is that it has to be given very slowly. And the reason it has to be given very slowly is that people react to it. People can get shortness of breath, they can get closing up of their airways, hives, and so it really has a risk for causing these what we call infusion-related reactions. And in order to prevent those type of reactions, we have to administer the drug very slowly. So especially for the first dose, patients may be at the hospital for 7, 8, 9 hours to get the infusion, because if they do get a reaction, we have to slow the rate down of the infusion. And so now at Princess Margaret, for those patients that are on daratumumab, what we've been doing is giving the first infusion over 2 days, because it makes for a very long day to try to get the first dose all in at once. So what this study looks at is, can we give it, rather than IV, can we give it subcutaneously? So it'll be a shorter infusion. And also, will it reduce the risk of getting these infusion reactions if we give it as a subcutaneous injection, so an injection just under the skin, like patients get bortezomib, for example. And if we do give it that way, again, are we getting the same amount of drug into the patients? And so this study essentially looked at 2 different doses of this subcutaneous injection. So patients were assigned to either getting a 1,200 milligram dose or 1,800 milligram dose. And they received it as we would normally give it, once a week for the first 2 months, then every 2 weeks for 4 months, and then monthly thereafter. Again, the question was, can daratumumab be given subcutaneously instead of IV to reduce the risk of infusion reactions and over a shorter time? This is all to sort of reduce the risk for safety and also to make things more convenient for the patients. And the answer was yes. Okay, so the subcutaneous infusion was well tolerated. There were decreased risk of infusion reactions, and the response rate was what we would expect, what we saw with the IV infusion of 38% response rate. So right now we are anticipating that we will be opening up a phase 3 clinical trial at Princess Margaret as one of the sites, where we will compare IV versus sub-Q. So patients will either be assigned to getting an IV or getting it subcutaneously. We hope that this will be a way for us to be able to get daratumumab to our patients while we don't have funding for it currently. So what about new agents? So we know that myeloma patients will eventually become resistant to lenalidomide, to pomalidomide, to bortezomib or carfilzomib, and as well daratumumab. So we need to continue to look for new drugs for patients. So data at ASH this year looked at Selinexor. So there was both the STORM and the STOMP study presented, and I'll go over both of these. So Selinexor, what it is a drug that essentially it works on the nucleus of a cell and prevents certain proteins that are important in causing cell death, to prevent them from coming out of the nucleus and they need to be in the nucleus to really have their effect. Then there was another study that looked at Venetoclax, which I mentioned to you is a drug that we used in CLL, and we're trying to see if it works in myeloma. And then this study of this antibody that's drug conjugated targeting BCMA. So as I mentioned to you, Selinexor, what it does is, this is the nucleus of the cell, and there are certain proteins within the nucleus that are important to be in the nucleus because they give signals to the cancer cell to die. And if you can block this exporting of these important proteins from going out of the nucleus into the cytoplasm of the cell, then they can exert their effects and induce cell death. So the STORM study was a study that was done predominantly in the United States. It was a phase 2 study, so everybody got Selinexor. There were 79 patients enrolled into that study, and those patients were really heavily treated patients, what we call quad refractory. So those patients had failed bortezomib, carfilzomib, lenalidomide, and pomalidomide. And there were even penta-refractory patients on this study. So those patients, in addition to those 4 drugs, had also either failed a monoclonal antibody, either daratumumab or ixazomib. So really, these are patients where really had no other treatment options available for them, and they were enrolled on this study. There were 2 different dosing schedules, 6 doses, 3 weeks on, 1 week off, or continuous explored on the study. And again, the endpoint was really the response rate and then the duration of response. And in that study, the response rate was 21%. You may think, well, that's not, 80% of patients didn't respond, but considering that these were patients where we had no further therapeutic options, it really does show that this type of drug does work in myeloma. And really the next steps are to combine it to get more activity out of the drug. To get better responses, we need to use it in combination. So that's the next study. There was the STOMP study, which is essentially, this was a Canadian-driven study that looked at combining Selinexor with standard treatments, either bortezomib and dexamethasone, or with pomalidomide, or with lenalidomide. At the ASH meeting this year, the data on the combination with bortezomib and dexamethasone was presented, okay? And what the study showed was that in 22 patients, the overall response rate was 77%, What was very impressive is in patients where bortezomib was no longer working, that when you added Selinexor, 67 of those patients were now responding to the treatment. And if you had never had bortezomib or were not resistant to bortezomib, the response rate was 100%. So it really does look like adding this drug to bortezomib increases the activity of bortezomib. Okay. So the potential side effects of this drug that we've seen is it does lower the blood counts, especially the platelet count. It causes fatigue, and there are issues with nausea, diarrhea, and loss of taste. The interesting thing that we found is when we use Selinexor by itself, like in the STORM study that I showed you before, side effects were quite significant. We saw a lot of patients lose weight, really significant nausea. But what we were surprised to see is when we combined it with bortezomib, the side effects appeared to be much less, which was quite surprising. So not only does it work better, but it actually reduces the side effects to combine it with bortezomib. And I just wanted to point out, during the meeting, this slide was shown, which basically shows and acknowledges the patients throughout Canada that were enrolled on this study, okay? So because this, as I mentioned to you, was a largely Canadian-driven study and run through the Myeloma Canada Research Network. And now, because the results were very good from this study, the company is now developing a phase 3 clinical trial where it will compare the efficacy of adding Selinexor to bortezomib dex versus just using bortezomib dex. This is really be the proof of principle showing that the combination is more effective than the standard treatment. And that study will be led by Dr. Nizar Baylis from Calgary. And Canada is taking the lead on this trial. So we're very proud of this Boston study, and you'll probably hear about it as time goes on. So Venetoclax. So Venetoclax is an important in inducing cancer cell death. What it does is there are a number of proteins within the cells, such as BCL2 and MCL1, and these proteins tell the cell not to die. So if you hit the cell with a cancer drug, these proteins, if they're enriched in the cancer cell, will say, no, you're not going to die, we're going to keep you alive. And what Venetoclax does is it blocks the effect of BCL2. So it makes it not functional, and therefore the cell can then die. But we know that we have myeloma cells, a lot of them, most of them will express not BCL2 but MCL1. They'll be more dependent on MCL1. But what laboratory data has shown us is that there is a subset of myeloma patients where BCL2 is more important than MCL1 for the survival of those cells. And so those patients may be the patients that we need to target with Venetoclax. And those are typically the patients that have an 11-14 translocation. So Venetoclax was studied in all comers in this phase 1 study, where essentially this was a complicated study because Venetoclax can cause tumor lysis and can cause patients to go into kidney failure. This is in patients with CLL. So this study was done where, in order to safely proceed, they started with very low doses of Venetoclax, and then they, after a month, went up to a little bit higher dose, and then again the next month went up to a little bit of an even higher dose. And there were 5 different cohorts. So first of all, they went up to 300, then the next group of patients received 600, and so on. And finally, the dose that was felt to be safe to use in myeloma was a dose of 1,200 milligrams. Again, the study looked at safety and the dose to recommend for phase 2 study, which is an efficacy study. And this was the results from the study. So the overall response rate was 21%, so not that impressive, but it does suggest that it has activity in myeloma. But what was very impressive was that if you had the 11-14 translocation, which was the group that we predicted would benefit from this type of drug, response rate was 40%. And then if they looked specifically to see if you had high levels of this BCL2 in your tumor cells, then the response rate was 86%. So this is now, we're approaching this area of individualized, personalized medicine, where we can say, you know, based on your particular myeloma, this is maybe a drug that you will benefit from. So again, here, so we have monotherapy that was well tolerated, a response rate of 21% in the overall patient population, but there were select groups that seemed to particularly benefit from this drug. And it supports the strategy of selecting patients for this particular drug. So the last drug that I will talk about is GSK 28579116. I can't wait till they actually give this drug a name. Okay. So for simplicity, I'll just call it 916. So this drug is an antibody like Daratumumab and Elotuzumab that I mentioned, but it is tweaked a little bit so that it has, in addition to being able to bind to the tumor cell by recognizing this molecule on the tumor cell called BCMA, it has a warhead, a drug that's attached to this antibody. And so when the tumor cell, when the antibody binds to this tumor cell, the antibody and its target are internalized. And then inside the cell, the drug, the toxin that is bound to the antibody is released, and it basically delivers this toxin to the cancer cell. So it works both by triggering the immune system to recognize the tumor cell, but also directly delivers a payload, a guided missile to the tumor cell, causing it to die. So this drug was evaluated in a phase 1 with a study with an expansion cohort, and the data was presented at ASH. And most patients, there were 30 patients presented at that time, where again most of the patients going on this study had exhausted all the conventional therapies. And we saw a response rate in the 10 patients that were treated at what we call the maximum tolerated dose, the dose that we feel is the dose that is going to move forward into phase 2 studies. 67% of patients responded, which is better than what you see with Daratumumab, where I told you the response rate was in the order of 30 plus. So really promising results from this particular drug. One of the downsides of the drug, of course, we always see side effects, but one of the concerns is that we do see eye toxicities. Usually the eye toxicities are reversible when we hold the drug, the symptoms get better. But moving forward, I think the interest from the company and from us, the investigators, is to try to figure out how to reduce the eye toxicities so that makes this a more palatable drug for patients. And also now we're looking at using this drug in combination strategies. And one of the combination strategies that we've proposed to GSK, and we're hoping that this will be a trial that will be run through the Myeloma Canada Research Network, is in combination with Pomalidomide and dexamethasone. So that is under review at GSK for now. So take-home messages. So for frontline treatment for transplant-eligible patients, so there is a benefit to achieving a higher quality response with induction treatment. There may not be added benefit to giving more intensive therapy after the transplant, but again, that is provided that your induction treatment is high quality. And that some new treatments that are in the horizon that will be investigated in phase 3 studies are the combination of carfilzomib, lenalidomide, dexamethasone given pre and post-transplant. Again, those studies showed very high quality responses, but we need to know now is, does that translate into long-term benefits for patients with myeloma? The studies also confirmed the benefits of maintenance treatment, both in transplant-eligible and non-transplant-eligible patients, and importantly, the idea that patients need to remain on maintenance treatment if they are tolerating it. And then for the relapsed patients, for the less heavily pretreated patients, really the use of Daratumumab in combination is where the future is at. The subcutaneous Daratumumab we're hoping will eventually come to the clinic for patients based on the phase 3 study. And I think this will make this a lot more convenient and palatable to patients to get it subcutaneously rather than the long IV infusions. For the heavily treated patients, we know that pomalidomide, dexamethasone, we can do better. And that is usually by adding a third drug, such as Daratumumab or carfilzomib or pembrolizumab. And that these PD-1 inhibitors really are starting to show promise in myeloma and need to be studied in various phases of the disease. And there are very exciting approaches on the horizon. We talked about Selinexor, Venetoclax, and BCMA-targeted therapies. So progress in myeloma therapy are due to research, and we would like to thank everybody in this room who has participated in research, and we would certainly encourage you to ask about what research is going on that may be applicable for you. And I would like to just acknowledge my colleagues at Princess Margaret Hospital. Many of you will be familiar with these names. As well as if you are interested in a clinical trial, you can contact Giovanni Pisa, and he can sort of let you know what trials are potentially available. If you're not a Princess Margaret patient, the best thing to do is to ask your own treating oncologist, because they can reach out to us, and then we can say, yes, we have a trial for this patient, or no, right now the patient's not eligible for a study. And then if you are eligible for a trial, they will usually make the referral to us for consideration for a study. And that's it. I'd like to really thank you for your attendance. And I know it was long, but I'm happy to answer any questions. Oh, sorry. Yes. So the question was the use of a salvage or second transplant. Do we still think it's appropriate, given all this exciting data from combination strategies that we see now in the relapse setting, to consider patients for a salvage transplant? Yeah. So we can certainly, I think we still think that a salvage transplant is a good approach for patients with myeloma, particularly if you've had a long response from your initial therapy. Because that gives us a good indication about how long do we think you're going to do with another transplant. So the longer the remission, then the longer your response usually to a second transplant. For example, if you have a 3-year remission with a second transplant, on average, we would see about a 2-year remission with a second transplant. If you have a 4-year remission, then you might get 3 years out of the second one. It's always usually a little bit shorter. So when we consider whether or not to offer a second transplant, we'll usually have the discussion with you and say, well, we think, based on our own experience and looking at our own data with salvage transplant, that you may get X number of months with a salvage transplant. These are potentially alternative therapies that may be available to you, and based on the studies, we anticipate that you may get 24, 26 months. And then we can have a discussion about which way to go with the patients. But certainly for patients who have 3 years plus, we think that likely they will get probably about 2 years, which is what you would get with carfilzomib, Rev, Dex. And maybe we can save those types of therapies for later. So we do definitely think that there's still a role for salvage transplant. The decision is really based on how long were you in remission with your first one, how did you tolerate it, and really what are the alternative approaches that we have available. The question was about vaccines and the role of vaccines in myeloma, and particularly with salvage transplant. So currently, I don't know that there are any clinical trials in Canada ongoing with vaccines in myeloma, but certainly in the US, there are a number of centers that are looking at various types of vaccines, dendritic cell vaccines. Those are all exploratory. It kind of makes sense to we know that, really one approach with just vaccinating is probably not going to be sufficient, that really we should be using various modalities together. So a transplant to really reduce the amount of myeloma, and then the vaccine to then try to sop up the residual myeloma using the immune system makes, I think, a very good sense, makes a lot of sense. So I think those kinds of approaches will be tested, and hopefully in the next few years we'll have some data on that. But I think really an immune type of approach in combination with doing a single a salvage transplant is a good way to go. The question was about, aside from, you know, sort of the efficacy data, that we know that a lot of the treatments we have cause side effects, such as neuropathy, and are there any updates on that particular area, right? With the amyloid as well, there are questions about amyloid and what are the updates from that perspective. So from the neuropathy point of view, I don't think there's been very much presented recently on dealing with the neuropathy. Unfortunately, I think we are all trying to work on new drugs that have less issues with neuropathy, and also ways of being able to deliver the drugs that we're using to have less neuropathy, such as using subcutaneous bortezomib, such as using once-a-week bortezomib, for example, or, as I said, with carfilzomib, the risk of neuropathy is much less. So when we're making a decision for a patient who has neuropathy, we have to keep all of that in mind to try to, as best we can, try to reduce the risk of exacerbating the neuropathy. But as far as specific treatments to reverse the neuropathy, I'm not aware of anything out there at the present time. Now for amyloid, there is lots of good stuff coming. There are antibodies that can potentially bind the amyloid and remove it from tissues, and there's some exciting data presented on that at ASH. Where we potentially can see some improvement in cardiac amyloid, for instance. So that, I think, is a very exciting area of research, and I do think in the next few years there will be some really good treatments for amyloid, irrespective of just standard chemotherapy types of treatments that we use. Okay, so for the first question about using genomics to treat myeloma. So, you know, we have this slogan at Princess Margaret now, it's in your DNA, essentially, right? So this is one of our big mantras there, is to try to develop personalized approaches for myeloma patients based on their particular tumor and the alterations within the DNA of the tumor cells that drive the growth of the tumor cells. We know that there are potential changes within the tumor cells that we call Achilles heels, that patients may have certain mutations in genes that may be driving the growth of the tumor cells, and if we are able to turn those genes off, the tumor cells may die. These are like vulnerabilities. And so yes, there's a lot of work being done at Princess Margaret Hospital. In fact, this is one of my areas of particular interest. In trying to find new drugs based on these sort of genomic alterations in the tumor DNA. So in particular, we will be opening up a trial in the coming months, I hope, provided we can get our contract done with Janssen, of a drug that targets FGF receptor 3. So we know that patients with 414 myeloma, so high-risk myelomas, may have mutations in a gene called FGF receptor 3. And at least in the test tube in the laboratory, it looks like those tumor cells may be very vulnerable to those types of drugs. So that study will essentially take patients with 414 myeloma. We will sequence the tumor cells, see if the patients have mutations. And actually this study has two arms, one where patients have no mutations but have the 414 translocation, and those that have a mutation, we'll treat them with the drug and see if we do see that the drug has activity in those patients. So we are calling personalized medicine. There is also going to be a trial of an umbrella type of trial that will be in a whole bunch of different cancers and will include patients with myeloma, that will be done across Canada, where myeloma patients will have their tumor sequenced, and then there'll be different drugs based on certain mutations that patients may have that they can go on this trial. So that is all ongoing. And excitingly, I'd like to sort of maybe promote our research a little bit more and say that we are now developing a test to be able to detect the mutations using a blood test rather than a bone marrow test, because we know that tumor cells release DNA into the blood, and that we can collect the DNA from the tumors in the blood and sequence those and look for mutations. And so That we've done a lot of work on that, and it's coming along nicely. So yes, so we definitely are exploring personalized medicine approaches for myeloma. And then the second question was regards to new treatments, potentially using sort of plant type of drugs that may then activate the tumor cells to tumor cells can die. Not familiar with the research from Windsor, unfortunately, so I can't comment a lot of how these drugs work. But the thing is that a lot of times a drug that can work in another cancer can work in myeloma. So if we do see that these drugs have activity in a different cancer and there's a scientific rationale that they may work in myeloma, certainly we would be keen on exploring those as well. For example, as I mentioned, Venetoclax is a drug that we use in CLL, and it does seem to work in certain patients with myeloma. So are there any clinical trials for 17p deleted patients? So we know 17p deleted, it leads to a loss of a gene called p53, and that loss, or what we've actually been finding now is mutations in p53 can lead to high-risk disease, meaning the disease that is very difficult to control and leads to shorter survival. So lots of effort is being put into these particular patients. One thing that we have found out is that through the COMPASS study, many of you may have heard about the COMPASS study. This was a study that looked at 1,000 myeloma patients. Bone marrows were done when patients were initially diagnosed, and the bone marrows, tumor cells have all been sequenced. And what we found is that not all 17p deleted patients are the same. And in fact, if you have a 17p deletion and a mutation of p53, those are the patients that are really the bad actors, that have the worst outcome. So this kind of information is very important because it may help us to really be able to further dissect out the patients that are really, really in need of new types of approaches, and those patients with p53 that may not do as badly as we thought, and maybe give a little bit of patients a little bit of relief when they think about their disease. So that's one thing. And then as far as those particular patients, we are looking at, we will be having a trial that is going to be open imminently at Princess Margaret, which is using an MDM2 inhibitor, which works in that same pathway as p53. And we think perhaps it might be useful in that patient population, again, that personalized approach, because it's within that pathway that's dysregulated by 17p deletion. And that trial is going to include this particular drug as well in combination with Ninlaro and dexamethasone. And that's a study that's being done through the Multiple Myeloma Research Consortium, which we participate in at Princess Margaret. As I said, right now it was a phase 1, and now they're moving into the phase 2 portion where they're enrolling more patients with 17p deleted myeloma. So we hope that that will show some promise. So the question was about CRISPR technology and whether or not there may be some hope for it in myeloma. So CRISPR technology is really cool technology that can be used to genetically modify cells. So it can essentially cut out a gene. So perhaps if we think a gene is driving tumor growth, we can maybe cut it out of the DNA of the cell and take out that vulnerability, that gene that's driving the myeloma. Or you can actually use it to put in a gene as well. So it's ways of being able to modify the DNA. It's used a lot in research, basically, to prove a concept for the basic scientists to basically say, if this target is important, I'll use CRISPR, I'll cut it out of the DNA of the tumor cell and do the tumor cells die. So primarily that's the use of CRISPR technology at the present time. I think it's going to be a long time before we can move CRISPR technology into the clinic. So primarily right now it's used in myeloma, but mainly for proof of concept, basic science research to basically answer questions. Why is lenalidomide not funded in the maintenance setting by Health Canada? So I think it's the question is really why is it not approved by Health Canada in the maintenance setting? So it is funded in the maintenance setting, but it is not Health Canada approved. The reason being is because the studies that were done with lenalidomide maintenance were phase 3 studies, but they were studies that were done basically run by sort of cooperative groups, by physicians, by cooperative groups. And the rigorousness of those studies are not as intensive as phase 3 studies that are sponsored by industry, meaning that the response results, for example, are not reviewed by a central body. They're not as rigorously evaluated as studies that are funded by industry, because those type of rigorousness to assess response outcomes are very expensive to do. So because of that, the company Celgene has not gone to Health Canada to get approval for len maintenance, because they don't have the kind of high quality data that would be required by Health Canada. And not only that, now, even though now they could probably go to Health Canada and say there are like at least 4 studies all showing the benefit, you should then approve it on the regulatory perspective. But I think right now it's kind of a moot point for Celgene to go through that type of effort, because it's essentially funded in almost all provinces anyway. So despite it not being approved by Health Canada as an indication for myeloma, it is still funded for maintenance, because the data was reviewed by the funding bodies, and they felt that the benefit of len maintenance was there based on the studies. And so they said that yes, they could approve it for funding based on efficacy. And then they probably said they would not approve it based on cost. But then what happens is that the provinces negotiate with Celgene, that makes lenalidomide, get the cost down, and then they say yes, now you can have it for funding. So it's not being reviewed by Health Canada for regulatory reasons for that indication, but it was reviewed by the funding bodies and approved by them, showing that it had efficacy and that the cost was now reasonable based on some negotiations with Celgene. It's complicated. Yeah, but that's a different thing, because funding is really by the provinces. The funding body in Ontario is Cancer Care Ontario. So each province makes their own decisions about whether or not they will fund the cost of a drug. Health Canada, really what it does is it says, yes, this drug is safe. First of all, that's the most important thing. And second of all, that the company has shown the quality of data that it supports its use for a particular indication, for myeloma patients with relapsed disease. Or so that's what Health Canada does. It says, yes, we have the level of data from phase 3 clinical trial that supports its use for a particular reason in a particular patient population. So the question was, do I have some idea of the prevalence of myeloma in Canada over the last few years, or do we have any clues about the cause? So I don't have data on the top of my head about the prevalence, but I do think that one of the reasons that we see an increased number of myeloma patients is patients are living much longer. So I can say that when I started my training many years ago now, patients are living almost 3 times as long as they were when I started my training. So obviously that's going to add to the number of patients with myeloma in Canada that are living with the disease. Overall, we do think that there probably is an increasing incidence. I mean, people are living longer as well, so it's a disease usually of patients of older age, 70 or above, so that's certainly another explanation. As far as other things that we know for causality, we still are in the dark where that's concerned. So I'd like to just thank everybody for coming and spending the afternoon with me here today. It was a long one, and I really wish you all very well. And as I said, please continue to be interested in research, participate in research, and with the walk, help fund the research, because this is how we're able to bring all of these new treatments to you, is for all the funds that you raise, and we're very appreciative of your efforts. Thank you.